I do live in Buffalo though, but I'm working on my master's in nursing education, so I've been precepting with Lorraine this semester with you guys. My area of expertise is hospice and end-of-life nursing. I've been in kind of the hospice field for several years, so I'm very comfortable and passionate about it. Throughout this presentation, I will probably be using terms that you may not have heard or you're not sure what they mean, so I encourage you to ask questions and, you know, initiate discussion if there's anything that you're not sure about, okay? So before we get started, the what, why, and how. So what we're learning today is typically all about hospice care at the end of life and the role that the nurse takes in this field. Why we're learning it? Well, you need to know it. You need to be tested on it in school, and then you're going to be tested on some of these concepts when you get to your boards. And then how are we learning it? Obviously, PowerPoint presentation, classroom discussions, and case studies. So objectives for this unit, we're going to be able to review the philosophy of nursing care and discuss what kind of care hospice provides. You'll be able to differentiate between hospice and palliative care. You'll be able to explain principles and ethical issues at the end of life. You'll be able to be familiar with pharmacological and non-pharmacological comfort measures with the terminally ill patient. You'll be able to identify psychological, emotional, and spiritual needs of the patient and family, and describe the care of the patient during the last hours of life and postmortem care. So what is hospice? Where do I go to click?
The mouse.
Okay. So actually for one of my assignments for school, I had to make a really cheesy video about hospice, so let's hope this works.
Oh, you made that video.
I made that,
oh.
Yeah. It was
when I was
awful.
looking at that video.
It's gonna go, well, if it doesn't go, but anyway, so to start off with just a statistic, so approximately 44% of people nowadays are dying at home, and that studies show 80% of people that have been evaluated are reporting wanting to die at home and not wanting to die in the hospital setting. Oh, there we go. So this is just kind of like a brief overview.
Why is hospice and palliative care important? Well, approximately 44% of all deaths in our country occur in the home or home-based facilities, and this percentage continues to rise. This impacts the discipline of nursing as it forces us to shift our focus from facility-based care to providing a large portion of care to patients in the community. For an end-of-life patient receiving hospice care, it is essential to recognize the goal of care as to provide comfort and to ensure the patient experiences a peaceful and dignified death. Common symptoms of the actively dying patient may include pain, terminal delirium, terminal congestion, and dyspnea. The good thing is that all of these can be managed easily with medications in routes such as subcutaneously, rectally, and sublingually. As patients transition into the end-of-life phase, they begin to sleep more and eat less, and become less and less responsive. At this point, patients may be bedbound and NPO. Patients may experience anuria, mottling, and other integumentary changes, and irregular respirations, which are all expected. One important component of managing an end-of-life patient in the home is to provide thorough education to the caregivers or family. This must be done using therapeutic communication techniques such as compassionate listening, active listening, therapeutic touch, and allowing caregivers or families to talk things out and ask questions. Families should be educated on the idea that patients are not dying because they're not eating, but they're not because they are dying. And encouraged to offer food for oral gratification only and to monitor for signs and symptoms of dysphagia and aspiration. Not only do we educate on end-stage signs and symptoms, medications, and how to provide physical care, but we must also address the spiritual, emotional, and existential realms of the end-of-life situation. Remember our goal: to make the patient and family as comfortable as possible and to provide support to aid in a peaceful and dignified transition into death.
Okay, so that's just a little kind of paraphrase of what we're all going to go through. So back to the statistic. It's almost half of all deaths in our country that are occurring at home, specifically with hospice care. So this is an absolute incredible statistic as far as I'm concerned, because over like the past century, it has just continued to increase and increase. So what exactly is hospice? Well, when you hear the word hospice, you tend to think, oh, grandma went to hospice, or someone went to hospice, and you think it's this place or this magical building. Well, it does have like an inpatient sort of component, but hospice is primarily an approach to care. So just like you would have maternity nursing or psych nursing, there's hospice nursing. It's a holistic philosophy or approach to care rather than a place. And it's also a Medicare benefit. So if you do in time get into hospice care, you'll have to learn about the reimbursement aspect of that. So hospice care is support and care for people in the last phases of their life when they are diagnosed with a terminal illness. Hospice focuses on quality of life, not only for the individual that's diagnosed with the disease, but also for their family, their friends, their children, everyone involved in that person's care. Hospice recognizes dying as the part of the normal process of living. So we see it as an organic, natural process. Hospice care also affirms life and neither hastens nor postpones death. So again, some things you may hear on the street is that, you go to hospice to die, or hospice, gives you meds and they kill you. But that's so far from the truth, and you'll see throughout this presentation. And then hospice is a service that can be provided in many different locations. Primarily, you'll see it in home care. Hospices do tend to have like an inpatient facility for acute or respite care. And Hospice Buffalo, at least, has the ability to provide hospice care at nursing facilities. So if you're talking about the Canterbury Woods, it's any degree of that, senior living apartments all the way up to skilled nursing. So, contrary to hospice, you have palliative care. Now, these two terms out in the community tend to be used synonymously, and they can be used, but as nurses, you need to differentiate the difference between the two. So, palliative care is a team-based approach that focuses on symptom management. So, the term palliative literally means symptom management. The people that can get palliative care are people that have chronic illnesses, acute illnesses, serious or life-limiting illnesses. The focuses of palliative care include caring for people at any age, at any stage of their illness. So that's different from hospice, where they're in that terminal end stage. Palliative care can be at any point in their illness. The focus is, of course, controlling their symptoms. A big component of palliative care you'll see is avoiding hospitalizations. So if you've got that CHF patient that has recurrent exacerbations, we're going to put a palliative care program in with them to reduce their number of hospitalizations and exacerbations. Another big difference between palliative and hospice is that palliative can be provided simultaneously with curative treatment. So you'll see a cancer patient that isn't necessarily a stage 4, but they still do have fatigue and weakness and pain and nausea. We're going to put palliative care on top of their curative care to help control their symptoms as they're going through that. So knowing that palliative care can go to anybody, hospice care has to be a terminally ill patient, physician certified terminally ill, and that palliative care isn't necessarily a benefit through insurance. It's just, again, sort of like a sort of product of symptom management. Any questions on that? All right, so back to hospice. So there are, as you saw in that little video, several goals of hospice. The main one that you know of is to provide comfort, of course. by relieving symptoms, physical, emotional, and spiritual, promoting dignity at end of life, which we'll get into the ethical and legal stuff, and then supporting the family. So obviously we know we're treating somebody's symptoms at the end of life, but we also have to remember to recognize that they're part of a bigger system and that their illness and their death is affecting so many people. And so when we're in that house as case managers or providers, we kind of have to look beyond the patient and make sure that we're taking care of the rest of the family as well. So what sort of services does hospice provide? So of course symptom management, again, that palliative aspect, and we're looking at all symptoms, emotional, psychosocial, and spiritual. Hospice facilitates getting medications to patients. If we're in a home care situation, it's collaborating with the physicians to ensure that the orders are getting to the pharmacy, that the drugs from the pharmacy are getting to the patient's home. We provide supplies, so wound care supplies, what else, like rubber gloves, like all that sort of bedside stuff. And we do facilitate getting DME or durable medical equipment into the patient's home, so hospital bed, oxygen concentrator, wheelchair, walker, all that type of stuff. Hospice provides family teaching, so as a case manager and as a nurse, your primary goal is to go in there and teach. I mean, you're going to be teaching until you're blue in the face with hospice. 99% of my day is health teaching. So, we're not only teaching about the disease progression and symptom management and all that, but we're teaching about how to administer drugs. We're teaching about side effects of drugs. We're teaching about how to physically care for a bedbound patient, things like that. Hospice can provide special services such as speech therapy, PT, OT, child life counseling, all sorts of stuff. So again, you kind of think at first hospice is comfort care, we're not going to really get any of these special services in, is it worth it? But hospice is actually a very progressive sort of care from what you're probably used to hearing. So speech therapy, I have a patient who she's 64, right? She's super young. She has an illness similar to ALS, right? So she's completely paralyzed from head to toe, but she's got all of her marbles. She knows exactly what's going on, and she can't necessarily communicate with me or her family and say, my leg hurts, or I have to have a bowel movement or something like that. So we've had speech in there probably 6 or 7 times as her illness has progressed to help us develop a plan of communicating. So it started off as a Dynabox, which is where she could press buttons and it would talk, and now she's at the point where she can't use her hands, so it's signaling with a finger or blinking and stuff like that. PT-OT would be a situation where you have a patient who had a lengthy hospitalization and they deconditioned a little bit, and they get home and they're not necessarily on that actively dying like track, so we put PT and OT in there to help gain a little strength back and show the family certain ways to transfer or ambulate, things like that safely. And then Child Life is a service that Hospice Buffalo provides. I'm not sure about nationally, but if there is either a pediatric patient that is in the hospice program, or if it's an adult hospice patient and there's young children, or like autistic children, or some sort of situation where there's a unique need, we do have specific Child Life counselors that can go in and sort of walk these kids through the stages of this patient's illness. Hospice also provides short-term acute care and respite. So short-term acute care looks like basically you have a patient in the home care setting that has uncontrolled pain or uncontrolled delirium, and the team tries as hard as they can to get it managed in the home, but it's just not working. They need more help. Instead of going to a hospital and calling 911 and defeating the whole purpose of hospice, they can come into an inpatient facility and get that treatment there with the goal of going back home. Also respite, like Professor Neal was saying, respite is a lot for the family members. So when you're assessing those sorts of things like caregiver burnout or role strain, anxiety, depression, things like that with the caregivers, hospice is able to provide, I think nationally it's up to 5 days of respite care at a time to help with getting a care plan set for the home location to make sure that the patient is safe and that they have quality of care. And then lastly, hospice provides bereavement care and counseling. A lot of what the interdisciplinary team does is help with funeral planning and arrangements. More often than not, these patients come into a hospice program with really no planning, because it's not something you necessarily think about. So we start with them right off the bat and kind of get it all squared away, so when the time comes, it's not this kind of big, tumultuous decision. Yep.
I thought with hospice care that they withdrew treatment, basically, for whatever the disease or disorder is. They don't classify PT and OT under treatment?
Mm-mm. No, I guess it's what the goal is. Treatment, everything is unique, and a lot of it is driven, well, most of it is driven by Medicare requirements and qualifications. So if you have a patient who is a cancer patient and they're metastatic, whatever, it's all over their body, and they're not really at the point where chemo or radiation or surgical stuff is appropriate, then they can come into program. But we're talking curative therapies. So chemo, surgical interventions, cardiac surgeries, that's the type of this sort of interventions that that hospice doesn't necessarily support, but things that would enhance the quality of life and not necessarily cure their disease, like these therapies, is certainly appropriate.
Can I insert?
Mm-hmm.
There was a while back, back in the day, in the late 90s, hospice used to have a whole facility called the Kresge Residence, and it's probably still part of, or something else now. But what the Kresge Residence was known for was it would take in HIV patients. And so basically HIV transitioned from being a disease where people were dying quickly to becoming a chronic disease. So what the Kresge Residence would do is, like, say if there was a HIV patient out in the community that needed a lot of assistance and supports and needed to get basically controlled, they would transfer them to the Kresge Residence. And so they would receive all these intensive therapies like the rehab, the physical therapy, the OP, the OT, all of that different stuff on a hospice-like level. And their friends and families could come and stay and spend, and stay with them and that type of stuff in a very homey atmosphere. And they got up to 5 months to stay there. One of the benefits of being at the Kresge Residence was it gave the families a break, and also because of the intensity and the level of services that were needed, but it also caused the residents who became residents there for the 5-month period, their benefits weren't changed. So they were still receiving, their government assistance and all that different stuff at home. So they were able to maintain like their family residence and basically go inpatient and get better, transition, become stabilized, still have this life-altering disease, and then be able to go back home. Okay? So like if she's talking about things like Lou Gehrig's disease or ALS, different stuff, you have somebody who's totally aware and with it, their body's fallen apart. And so how can you maintain or ensure quality of life while they're falling apart? Get it? So sometimes, just somebody might celebrate being able to raise a toothbrush to their own mouth.
Right.
And you don't want to take that away. Okay?
So it's all about enhancing quality of life. So if we can get PT or OT or speech or something in there to enhance their quality of life, we know that having speech therapy in for my 65-year-old patient with ALS isn't going to cure her ALS. It's going to increase her quality of life. It's going to make managing her illness easier because we now have ways to communicate with her. Also important to remember that hospice doesn't mean giving up, doesn't mean, we're just going to put a person in a bed and forget about them until they die. I mean, hospice care is very progressive, and we'll do pretty much anything that we can under the realm of the Medicare requirements or qualifications to make the end of this patient's life like as best as we can. So quickly back to bereavement. So hospice care under, again, Medicare, the Medicare benefit, provides 13 months of bereavement care from the date that the patient passes. So any idea why it's such an obscure number, 13 months?
If a family doesn't really have any end-of-life planning or any funeral planning, this process can take a fairly extended period.
Right, so it's a pretty significant amount of time. So let's say that patient A dies in January 3rd, okay? So we're gonna offer bereavement, keep in touch with that family or caregiver or whoever is receiving the bereavement up until January 3rd, and then also up until February 3rd. Why?
Because a lot of times that first year, especially the anniversary of it.
Exactly. Right, so it's really cool how they've kind of built that into the system, that we're getting these family members, spouses, whoever, through that first death anniversary. That's studied and proven to be the biggest hurdle in the first year, is that first death anniversary. So we're able to provide that care and counseling, and then of course, like I said, planning throughout the admission into the hospice. So attitudes towards death and dying. So this is always, something that I like to discuss with people, and that as a nurse in hospice, we go in and we're assessing these sort of attitudes. Do you guys feel any certain way about death and dying? Is there anybody that particularly feels very comfortable talking about or dealing with patients who are terminally ill or had any experience? Yeah, so a few of you, but generally speaking, you guys are, for the most part, a young group of people. You may not have experienced any, huge, big things. I'm just generalizing. I'm sure, everyone has their own situation. But generally in our culture, we are a death-denying sort of group of people. From a medical standpoint, we see death as failure. So, you see in the emergency room or ICUs, their goal is to make this person better and to get them back to their baseline. Their goal is to keep them alive. And if they don't keep them alive, then those providers or those teams or organizations feel like they haven't done their job. Everyone obviously has their own view of death and attitude towards dying based on their personal experiences. And fear has been proven to be the most common attitude towards death. And then certainly attitudes towards death change over a lifetime. So a younger person may feel differently, a 20-something may feel differently towards the idea of death and dying than somebody who's 80 and has lived their life and has had their family and everything like that. Another thing to understand about hospice and being the hospice nurse or caring for a hospice patient at a hospital is that you have to kind of have a little bit of self-reflection with yourself as a nurse. How do I feel about death and dying? Am I going to, push my fears or values or beliefs onto this patient or family because I don't feel comfortable with it? Going through that self-reflection and, kind of identifying how you feel before you can provide the care to the patients and families. So again, American society tends to deny the reality of death based on their experiences, and a big thing is obviously cultural factors can significantly influence their reaction to their illness and their process of dying. With that, we've got different religions and belief systems that hold different ideas in death and mourning and the process of dying. All right, so what kind of patients do we see in hospice? What's the first thing that you think of as being a hospice patient?
Cancer.
Cancer, right? So, okay, cancer is the most popular hospice diagnosis nationally. It does, however, only account for 1/3 of the admitting hospice diagnosis. So as you can see here, we see several different diagnoses. Cancer being obviously the most, but dementia, heart disease, lung disease, cardiovascular disease, renal, liver, debility unspecified, that would be like somebody who's just old, and there's really nothing that we can grasp at. There's no specific diagnosis, but we know that they're dying and that it's just their body shutting down. ALS, and then HIV/AIDS. I think that is so interesting because, right? I have worked in hospice a cumulative of almost 6 years, and I have had 2 HIV/AIDS patients. That's it, just 2. I mean, and you see the prevalence of the condition, but as Professor Neal has been talking throughout the classes, because we have better prevention, detection, management, we're seeing less and less of this in end-of-life care, which is awesome. And then, like I was mentioning, to be eligible for hospice, you do have to have, I mean, this isn't limited. I mean, there's many more than this, but the illness has to be of Medicare criteria. So it has to be physician certified that this patient has a terminal illness. And that they have to be on board with the philosophy of nursing, which is, you know, comfort care, not going and getting any sort of curative treatment, and having care limitations. All right, so a quick case study. So we have a dementia patient. So take a minute and read this, and then we'll discuss it.
You could sit here, she said. I could be over.
Is that hard to see, guys?
Oh, she's just blind in the back. She alright. She took her glass and put them on top of her head. Just saying. Just a quiet cameraman.
Okay, so we have a patient here. Female, she's 84 years old. She has a diagnosis of dementia. She's had it for 12 years. Okay, so usually the lifespan of somebody with a diagnosis of dementia is about 10 to 15 years. So we can kind of gather that she's towards the end of that. She lives and is cared by her 62-year-old daughter, Marie, for 5 years. She's providing great care, but despite she's had 3 hospitalizations for recurrent aspiration pneumonia just within a year, and she's no longer able to communicate and has been losing weight without trying. Okay, Marie, the daughter, isn't sure she can really manage the care anymore. The goal is for the patient to stay home, but she's feeling very stressed, so on and so forth. The caregiver still remains stressed, confused, really doesn't know what to do, and is looking for some help. So, do we think that this is a hospice appropriate patient or not? Why do you say no?
I don't think her quality of life is at the point where she needs to go to that
Okay.
extent.
Okay.
It doesn't seem like she's a terminal case, quote
Okay.
unquote, per se, where it's something that it's very close she would, I don't wanna say never come back from, but she couldn't maintain a decent quality of
Okay.
life. I think, in this case, perhaps either transition to an assisted nursing care facility or perhaps some home care.
Okay. Anybody else? So this is actually a real hospice patient. Okay, so definitely hospice appropriate, and I'll tell you why. She's got a diagnosis of dementia that we know is not curable. She's had it for 12 years, so we know that she's kind of at the end of that sort of thing. She wants to stay home, and she has a viable caregiver. She has had 3 hospitalizations in the past 10 months for aspiration pneumonia, okay, which means that she's eating, but she's aspirating and she's getting pneumonia. So 3 times in 10 months. She's no longer able to communicate effectively, so she can't make her needs known. And she's been losing weight steadily despite having, you know, fair nutritional intake. So even just with that kind of medical history, if I was going and meeting this patient, I would suggest hospice care for them because the patient is clearly declining. Okay, the aspiration pneumonia. Once you have dysphagia from dementia, you don't not have dysphagia from dementia anymore. So she's just going to continue to be declining, and she's going to continue to have aspiration pneumonia until she dies from an infection.
Hospice doesn't have a timeline, does it?
So yes and no. So under the Medicare benefit, hospice.
Because I've just never heard of patients being on hospice for years and years.
Yeah, our book had used says 6 months.
So under the Medicare benefit, a patient admitted to hospice has to have a prognosis of the date of admission of 6 months or less. So when we come in, we say, all right, based on this patient's medical history and the trajectory that they've had, we can assume, or we can presume, that in 6 months they won't be here. So that ALS patient I was telling you about earlier, 64, you know, totally dependent, she's been my patient for 2.5 years. So they're really, there is no cutoff. So at 6 months, if you're still alive, we don't kick you out. Basically how it works, and you guys don't need to know this, but just for your own knowledge, basically how it works is when you're introduced to the hospice program, you have to be recertified by a physician and a nurse every few months. So like every 2 months, I go into that patient's house with my doctor and we do a complete assessment. We compare it to the last recertification period and we say, has there been decline? And if we can prove decline to Medicare, then they stay in the program. So I've had a patient, well, it wasn't my patient, but in our organization that has been in hospice for 4 years, but she has steadily declined over 4 years, okay, and we can prove that. But criteria for admission, it has to be an illness that from that day, if that trajectory goes as you know, in that straight downward line, then the prognosis is 6 months or less. And the average stay in a hospice care, I think, is like 21 days. So it's rare that we have those outliers, but it does happen, and we do support them through the end of their illness. Or we discharge them because they've plateaued and we can't confirm or we can't prove that they've made any significant decline, and we discharge them, and they go on, you know, we reattach them to their community resources, and sometimes they come back to us, and sometimes they do too well. So back to this lady, Mrs. Smith, she's definitely a good patient for hospice care, even more so because the caregiver is clearly needing help. The caregiver needs some assistance. It looks like they may need some DME in there, some teaching, some case management, some support. Okay, and then a CHF study, so congestive heart failure. Take a minute and read that one. Oops, sorry guys.
Oop.
Oh, how do I go back?
You can,
That's my cool method.
yeah, you can go previous, like you can put the little arrow.
Yeah, I don't know how to do
Get
that.
that, get it there. Don't worry, I got it.
Okay. Okay, what do you guys think? Hospice appropriate?
Yes.
Anyone think he's not hospice appropriate?
It's possible if this is only an exacerbation of his condition.
Okay.
It's a riding the fence answer.
Okay, so it's definitely a hospice appropriate case. This is a real patient.
You're
So-
dying and you're dying. Everybody's.
Right. And so, I mean, there is an aspect of it that they could have all of this going on and they could be hospice appropriate, but it's not what they want. And so then they wouldn't be hospice appropriate, but clinically, the presentation clinically is that they're appropriate for hospice. So we've got Mr. D, 75 years old. He's got a wonderful, huge cardiac history here. So CHF is his primary, CAD, ischemic cardiomyopathy, CVAs. He's had several surgical interventions, 2 cabbages. He has an AICD. He's had 7 cardiac stents. That's a lot. That is a lot for being 75. So he's cared for at home by his wife. He has, in the past year, been hospitalized 4 times for CHF exacerbations. Throughout this year, he has had a decrease in appetite. He's having more difficulty ambulating, more weakness, more short of breath. He has gained 30 pounds, in 2 months, thus experiencing a bed-to-chair resistance. So he's not going anywhere. He's in his bed or he's in his chair, and that's it. He is on O2, he has 2 to 3 plus pitting edema, and he has a PPS score of lower than 50. So PPS score is like a hospice thing. It is stands for Palliative Performance Scale, and goes 0 to 100. We are 100. This guy is halfway there or lower. And so his caregiver has provided excellent care, and they believe that they now need some additional help in keeping him home and to manage his symptoms to avoid going back to the hospital. Totally appropriate. All right, so hospice is provided by a team, okay? Intercollaboration, you'll hear different, types of words, but the IDT is the interdisciplinary team. Call it multidisciplinary team, however you see it. And together we provide care to the patient in a holistic manner. So who knows what holistic means? And
Natural.
okay,
See the patient as a big collective group.
okay,
It's not just pain, it's also how's their appetite, how's their movement.
okay. So yeah, so the concept is that we are providing care and assessing needs for all different realms. So back earlier in the slides, we saw that we're going to be attuned to emotional distress and spiritual distress and caregiver issues and role strain and things like that. So we're not just looking at the physical, we're looking at emotional or psychosocial things like that. So with that, we obviously need a team of different types of disciplines to coordinate that care. So you've got your patient and family in the middle. Hospice is patient and family-centric care. And around that, we have all of the different sort of disciplines that come together to provide care. So obviously physicians, nurses, therapists that we talked about, home health aides, bereavement counseling, social workers, spiritual counselors, chaplains, priests, whatever you want to call them, and then pharmacists. Pharmacist is the best thing ever. I'm not sure about nationally, but here locally we do have a staff pharmacist with Hospice Buffalo that is incredible, and she is such an important part of this team because we're slinging drugs all day, every day, and to make sure that it's safe and that it's effective and optimal, we utilize her very frequently. And then just a reminder that hospice doesn't necessarily provide a physician. Hospice Buffalo again does because we're awesome, but they most of the time have a community physician or a cardiologist or an oncologist that as case managers, and as the team we're collaborating with those community providers. Excuse me,
okay.
I just wanted to,
Okay.
you got it? So I just want to show you a quick video. It actually is a Hospice Buffalo patient that I had on our team and that I helped care for him. And it's just kind of an idea of what we provide with that interdisciplinary team at home. So he had cancer. He's since passed, and his wife had cancer and passed like 6 months before him. So she passed, and then he came into our program and passed. So we were really familiar with the family.
That's it.
That's all right.
No more oxygen.
That was wonderful. Where did you
I
last play?
misplay. When my wife's last surgeon said she can do no more for her, my question was, well, what does that mean? And she said, she's at the end of her life stage. We can do no more for her. We will do no more surgery. There's nothing can be done to prolong her life. And I asked, well, what do I do then? And they recommended hospice. I would then put in contact with one of the hospice representatives, and they explained the whole hospice program to me. I told them about my medical background. I asked them what I was able to do. They explained everything in such detail. We just kind of looked at each other, my wife and I, and said, this option of being able to die at home is wonderful. We just followed the orders that hospice gave us. We laughed with her when she could laugh. We cried with her when she no longer was feeling those things. I was holding her hand the day she died. And I knew she was taking her last breaths. And if a husband has to lose a wife that he loves dearly, there was no better way than for me to lose her that way. Yes, I have bone cancer, I have lung cancer, but at the moment I'm speaking with you, I'm pain-free. I experienced a lot of negativisms from the chemicals. Obviously, I lost my hair, lost my appetite, lost my energy, lost my will to live. I lost it all. And actually, I prayed that God would take me because I had nothing left. I was a very, very sick man. And that's when I said, I need hospice. I knew exactly what was going to happen because I went through it with my wife. I know exactly what's going to happen today. Now, some people will accept that and say, how do you feel about that, Robert? You know what's going to happen. Yes, I know. And I know when it's going to happen, and I know how it's going to start, and I accept that totally. Knowing that I've got the help I do from hospice, and they're going to keep me pain-free, they're going to be here when I need them. More nurses will come. More aides will come. They'll be the nurses that you would get in any hospital, but it's not a hospital. A hospital is a hospital, it's not a hotel. My house, my home is my hotel. And they'll make me as comfortable as I can possibly be for as long as I'm breathing. I have a social worker that works with me with regard to any social problems I have. I have a chaplain that works with me, comes to see me frequently with any issues I have. I pick up the phone anytime I want, and I've got someone from hospice here helping me. And I thank hospice for that. Try to share with people what I feel in my heart about the services I'm getting so that I might possibly be able to help them to make a better decision when they and their family have to make the decision as to what they want to do. It's a difficult decision, very difficult decision. Having been in medicine as long as I was myself, and having to make that decision with my wife, not sure of what I was going to get. But once I got it, I knew this is what I wanted for myself. It's the friendliness, the compassion, first name basis, the honesty. I'm speaking from my own heart. I'm speaking the truth. So hospice not only offers superb medical, they offer, I think, in my own heart, that compassion that I wouldn't be able to get anywhere else. I'm hoping that by seeing what I'm going through and how I'm going through it, they see what faith can do, they see what hospice can do, they see what family love can do.
So you can see in that video, real life hospice patient right in Buffalo, how we had we had a chaplain in that video, we had a social worker, a doctor, a nurse, he had home health care aides, and you can just see how collaboratively we treat this patient holistically. So we're looking at all realms of this patient's care. All right. Okay, here's my favorite little thing here. So we are the nurses. So what does hospice nursing look like with us? So this is so funny. I saw this as I was scrolling looking for pictures and stuff, and it says, I'm considering changing my job title. How does bowel movement supervisor sound? Because that's how I feel every single day. I'm just constantly asking people about their bowel movements. So the role of the nurse. Like Professor Neal said a few weeks ago, case managers, nurse case managers, we are like the wedding planner of the medical field. I mean, like, we just really cover everything. If the patient doesn't have a bowel movement, they call me. If they need to get their drugs from the pharmacy, they call me. If they're awake at night, well, they don't call me. But if they're awake at night and they can't sleep, they call me. If their car won't start, they call me.
Yeah, I was called to change somebody's shower head.
Oh, the things that I've
They
done.
blew up my pager.
I've
You
changed
gotta
someone's
come.
flat tire. I've done
Yeah,
some
I did
incredible
tires
things.
too.
Yeah.
I'm like, really?
Just crazy stuff. I've picked people's kids up from school. Like, don't tell anybody. But
Went
like,
grocery shopping.
Just crazy stuff.
Took
like,
them fishing, and I don't even fish.
Yeah, yeah. So really think of the role as the hospice nurse as you are really just taking care of everything. So why? We spend the most time with the patient. We're in the home. We're there weekly or 3-4 times a week, depending on their needs. And so we become that point person for them. We're responsible, of course, for developing, facilitating the plan of care with collaboration with our team. We attend to the physical, emotional, psychosocial, and spiritual needs. So I'm not a social worker, I'm not a chaplain, I'm not a doctor, but I wear many hats. As a case manager with hospice, you kind of have to go in with that holistic mind and truly, be able and be comfortable to assess all the needs, because you're going to be the one making the referral to the chaplain. You're going to be the one calling the social worker when you see that they need some assistance with their bills or something like that. So you need to be aware of how to assess for those certain needs, not just if someone's in pain and they're rating it at a 10 out of 10, not just if someone's having constipation. Another big role of the nurse is, like I said, is providing education. I go into the house, and from the minute I open my mouth till the time I'm in my car, I am educating this patient and family. If I'm making a medication adjustment, I'm educating them on why and when and all of that. If I'm boosting a patient up in bed, I'm teaching them how to do it. If I'm talking about how I'm going to manage their symptoms or talking about how their disease has progressed, I'm educating them. Okay? The nurse is an advocate and the communication bridge. So again, we're the wedding planner. We're the ones calling the community physicians. We're the ones calling the pharmacy most of the time. We're the ones calling other family members. You know, if there's an out-of-town daughter or something and this patient's making changes, I'm on the horn and I'm calling and saying, hey, here's what's going on. So the nurse is that bridge between all other components of this patient's care. Of course, we are providing culturally competent care and postmortem care. So postmortem care is pretty specific to nurses. Nobody else can do that. So remember that you are everything to your patients and families. So a couple things to highlight about communication and education as the nurse is that you want to be able to build this professional nurse-patient relationship. So get to know your patient and family. Remember that you're in their home. You are on their turf. So you take your shoes off if it's clean. Or, you know, if they offer you a cup of coffee, take the cup of coffee. Like, make them feel comfortable. You know, I know Lorraine has said in her previous classes, you know, you want to build that relationship with them, so when you're telling them to do something, they trust you and they want to do it. You know, you want to ensure that they're compliant with your directions. So if you go in and you're being nasty or you have an attitude or you have a look, they're not going to take what you say seriously. They're not going to want to follow your instructions. So keeping everyone informed as the disease progresses or doesn't progress, keeping them informed of what the plan of care is as it changes, being consistent and honest. One of the things that hospice nurses pride themselves on is being honest. I mean, I have a finesse for going into a patient's house and telling them that they're dying. I feel completely comfortable with it. I have no fears or anything, and that's something that as a hospice nurse you have to be comfortable with, talking about that. Talking about, you know, sitting across from the table with a patient saying, how do you want to be buried? Do you want to be cremated? You know, what do you want to do, you know, with your family or whatever the case is. And then obviously making sure that you're paying attention to everybody's needs, okay? A point that's not up here to remember about that is that a lot of times when you're talking about hospice care and end-of-life care and home care, there is a tendency for people to get too attached and kind of cross that line and really overstep their boundaries of that professional relationship. So I'm not sure if you guys have taken psych courses yet. So oversharing information or becoming, you know, visiting the patient unofficially when you're not working, or you know, giving them your personal cell phone number and texting their family members or texting them. That's all kind of drawing, you know, got to draw the line somewhere. It's you're really doing yourself a disservice and your family and patient a disservice by, you know, not being professional about it. So again, points that we do with health teaching and education, maladministration, care for the bedbound patient, the progression of their disease, home safety, and just the overall plan of care. All right, so what does end of life look like? So what is the biggest symptom that we tend to treat? Pain, right? Pain's the biggest, especially when 33% of our patients are cancer patients. So pain has a lot of different offshoots. So we've got physical pain. So when somebody has spinal mats, they've got bone pain, right? If somebody has pain and it's really affecting their quality of life, it may inhibit them from going through their religious obligations, so going to church or receiving communion. Or pain may just take them down so far as not being able to identify as their old self again. So you kind of get the spiritual distress. And then emotional pain, so they know that they're in pain, they know what the pain means as it increases, and the emotional distress that kind of comes with that. So pain is usually the biggest one. The other end-of-life symptoms that we see are dyspnea or shortness of breath, nausea, vomiting, anorexia or cachexia. Does everyone know what cachexia is? So anorexia is when someone doesn't eat, whether they're doing it purposely or not. And then cachexia is sort of like the muscle wasting and the when you see someone who's cachectic, they're frail, they've got the temporal wasting, you can see their ribs, you can see all their bony prominences. So those two tend to go together. Weakness and fatigued, as disease progresses, patients become more weak, difficulty ambulating, and they tend to fatigue more easy. Constipation, again, is like, I should have put that in the pain bubble because everyone's constipated at one point or another, whether it's from medications. So what medication tends to constipate people?
Opioids.
Opioids, okay? And we use tons of opioids every day. So constipation can be from that. It could be from decreased mobility. They're not eating. So it's like a perfect storm for constipation. And then delirium. Delirium, again, can come from multifactorial things. So we can have delirium from medication side effects. When somebody has a disrupted sleep cycle, so if they've got that sleep-wake state that's all disrupted, it can kind of trigger them into delirium. It could just be like an organic process. A lot of times when patients are approaching the end of life, it's just like their mind isn't catching up with their body, and then they just end up becoming delirious. But delirious is reversible. Yes. So delirium is reversible, so we use medications to kind of alter that and get the patient back to their baseline. So this is another, I'm like a mean girl. So this is another one that was so funny, and I'm sorry if I offend anybody, but this is like what a hospice nurse is. So it says, listen, I know this is a difficult time, but when was your last bowel movement? So this patient's dying, and you're like, when was your last bowel movement? When, we need to know this. So bowels are super important. All right, so types of interventions that we provide in hospice. So obviously, going back to physical symptoms and things like that, we're going to use medications. We mostly use opioids for pain, steroids for pain and breathing, anticholinergics. Does everyone know what that is? It's when we dry up. Anti-anxiolytics, so for anxiety, laxatives, etc. And then we provide these pharmacological interventions via many different routes. So first one being by mouth, sub-Q, IM, rectal, sublingual, IV, and intraspinal, but that should be intrathecal. Yeah. So you think hospice, we're not going to do IVs and we're not going to, access a Mediport, but that is totally not the case. I mean, I've had a patient on TPN before. We actually flush Mediports every month and keep them patent because we end up using them sometimes. As the patient follows through in their progression of their disease, they tend not to be able to swallow anymore. So we have to get smart, and so we'll use sub-Q ports in the home. We'll do IM injections if it's indicated. Rectally, again, we love the rectal stuff. We do have this new cool thing called a Macy catheter. I don't know if you guys have ever heard about that, but it's actually a catheter that goes and is inserted in the rectum just like you would blow up a balloon with a Foley catheter in the bladder. It goes right into the rectum and it stays in there, and you can push meds through it, and it gets absorbed in the rectal mucosa. So that's for people who are bedbound but still need comfort meds, or not bedbound, mostly unresponsive, they tend to
How are they pooping?
It's at the point where they're not usually having bowel movements.
Oh.
We're talking the last 3 to 5 days of life.
Okay.
So people who are on an end-of-life trajectory tend to stop pooping after a while.
Mm-hmm.
So, but just so you know, if they do have a bowel movement, it just pops out and you just put it back in.
Oh.
It's super cool. Yeah. No, really, it's fun. So,
It's fun.
So, okay, we got our medications. So non-pharmacological interventions, massage therapy. Hospice Buffalo offers that. I'm not sure about nationally. I'm sure, depending on county or state, it depends. Physical therapy, music therapy is awesome. Aromatherapy and guided imagery. So we're talking about things that aren't necessarily giving them medications, but if someone's in pain, going through that guided imagery sort of thing and getting them back down to a nice, easy level. Aromatherapy is one of my favorites. And then, interestingly enough, palliative chemo and radiation. So, kind of to piggyback on your question earlier, we do support that. And hospice does support that. Again, it differs between hospices, because each one is kind of a standalone. But as far as the general, population of hospices, this is something that is supported. So this is a situation, for instance, I had a patient years ago. She was in her 70s. She was still, at the point where she was up, walking, talking, she was eating, she still could, kind of function normally. She was at a PPS of maybe 60, but she had brain cancer. We knew it was terminal. We knew there was no cure for it. Curative measures weren't necessarily, effective, so she came into hospice. Well, she had this tumor that just kept growing and growing and growing, and it was impeding her quality of life. It eventually gave her debilitating headaches. It eventually put so much pressure on her optic nerve that she went blind on her right side. And for somebody that's up walking and talking and still some quality of life, that's a big blow to have that blindness and to have those debilitating headaches. So now you're in bed, now you're dependent on somebody for your eyesight and things like that. So she actually went and got palliative radiation therapy on that tumor to shrink it. We knew that the radiation wasn't going to cure it or get rid of it, but it was going to shrink it enough so that she can regain some of her eyesight and have some quality of life. So that's a situation where you would see palliative chemo, palliative radiation. Does that make sense? And then a cool new one is this medical marijuana, right? It's for the cool kids. But recently in Buffalo, we opened up the cannabis clinic at Dent Towers because New York State has finally legalized the use of marijuana for medical purposes. And it is a huge thing in the hospice world. I mean, we had to have like extensive training. Our physicians had to go through this whole certification thing. But more and more and more, we're seeing patients either coming in to the program and they're being treated with medical marijuana, or they're kind of like self-medicating and it's not necessarily a medical thing, but you'll see cancer patients that are like, by the way, is it okay if I like smoke? And I'm like, I don't care what you do, but this is going to be a trend that as you guys kind of infiltrate the work field, you're going to see that medical marijuana is going to be a more popular sort of intervention, not only for hospice, but for palliative care and other things. So that is something to remember. All right. Let me just check my notes. So now we're looking at a patient who is at the point where they are actively dying. Okay, they've been in program, we did this and that. They're at the point where they're bedbound, and they're within that 3 to 5 day or 2 to 1 day sort of phase in their lives. And there's indications of death that as providers and nurses that we're going to be assessing for and noting that would indicate that this patient is imminent. So this patient is bedbound. This patient is unresponsive for the most part, or minimally responsive. You're going to see increased secretion. So as when we go throughout our day, we're swallowing. We don't even know we're swallowing. We're swallowing our saliva and whatever. We're negotiating that stuff. But these people are totally comatose. So they're going to have the increase of secretions. We're going to see the cachexia and the dehydration, the poor skin turgor, the wasting, the bones, things like that. Their skin integrity issues. They may have wounds just from being immunocompromised and being bedbound. They'll be incontinent, obviously, and then a lot of times we do see that terminal delirium. So the buildup with the secretions, you may have heard the term death rattle, or you may have heard a death rattle before. We hate saying that, but that's kind of what people know it by. But basically it's just a little bit of saliva that sits in the back of somebody's throat and just like rattles. And it sounds awful. And I can hear it driving up their street. Like I know it's coming. And it sounds bad. It sounds like they're just full of fluid and secretion, but it's really just like a little piece of saliva that's reverberating in there. So the death rattle. Changes in respiratory patterns. So Shane Stokes breathings, have you heard of that term? So that's when somebody goes from having these long, deep breaths and then change to the shallow, rapid respiration. So that kind of agonal breathing. And then their skin, obviously, cool, clammy gray. And mottling, does everyone know what mottling is? So it's kind of like a purpley, spiderwebby pattern that you'll see generally on the soles of the feet, the knees, the elbows. It can come and go throughout those last couple days. Some people get it, some people don't. I had a patient who I was actually there for her death. I was probably in the house for maybe 2 hours as she was kind of transitioning. And she went from having modeling from head to toe, I'm talking like purple head to toe, and then I like turn away to do something and it was gone. So it's a circulation thing, things are misfiring, so you may see that, and that's a good indicator that somebody is really at the actively dying stage. All right, so a task that nurses have to do, not only in the hospitals, but in home care, is postmortem care. So has anyone had to do postmortem care in their jobs or seen it or anything like that? So how do you feel about that? Yeah, seeing a dead body, it's weird, right? I mean, not for me,
Oh,
but.
I mean,